Swayam Prabha. Digital India. Educated India.
Welcome to the talk on the evaluation of the axillary nodal basin and the lymph node involvement in patients with invasive breast carcinoma. And we shall discuss the current consensus, the opinion of the experts as to how to evaluate the axillary lymph nodes in patients with carcinoma of the breast, and what are its pitfalls and how can we overcome or circumvent the current issues. Lord Monaghan, a famous surgeon in Britain, stated that surgery of the malignant disease is not the surgery of the organs, it is actually the anatomy of the lymphatic system. And with this, ushered in an era of radical lymph node dissection, also called block dissection. We hear of William Stewart Halsted performing the first radical Halsted mastectomy, where he removed the entire axillary nodal basin, started way back in 1882. Then came George Washington Cryle, starting the radical neck dissection in patients with head and neck cancers in 1906. And a year later, Ernest Miles in London performing the first rectal cancer in the form of abdominoperineal resection, where again he performed clearance of all the lymph nodes located in the pelvis in the juxtaposition of the rectum and anus. Very soon, surgeons and their patients realized that there were issues related to radical block dissection, such as pain due to cutting of the sensory nerves, paresthesia or anesthesia, again due to unnecessary dividing or removing the sensory nerve endings located in the nodal basin. Lymph nodes are essential for drainage of the lymph from the organs, and removal of these lymph nodes and lymphatics leads to collection of fluid in the tissues or organs called lymphedema. So in radical mastectomy, we saw a lot of women developing lymphedema of the upper arm in 10 to 30% of patients, and similarly in patients undergoing radical dissection of other organs had collection of lymph. Wound infection was fairly common, and this would lead to breakdown of the skin wound and surgical site infection. Moreover, it was realized that in patients where lymph nodes were negative for metastasis, this operation was futile and totally unnecessary. Let us now come to the evaluation of the axillary lymph nodes in patients with invasive breast carcinoma. In this cartoon, we are trying to show you the primary tumor where lymphatics from the organ, in this case the breast parenchyma, carry the lymph along with the tumor cells to the first station or first echelon of the lymph nodes located low down in the axilla. They are called the level 1 nodes. Actually, they are the pectoral nodes located just lateral to the pectoralis major and minor muscles. And it has been found that about 90% of these nodes are located between the pectoral muscles and a vein which is tributary of the axillary vein. This vein is called the lateral thoracic vein. So 90% of those nodes are located in this area between the lateral thoracic vein and the lateral margin of the pectoral muscles. From the efferent of these nodes emanate and go to higher echelon nodes called the second echelon or higher second station nodes. From there, the efferent will carry the lymph and the tumor cells to the higher order nodes, and this will then continue. This anatomical presentation again demonstrates the presence of very rich lymphatic plexus in the breast parenchyma and in the overlying skin and the nipple areola complex. All these lymphatics converge to a set of nodes located between the pectoralis major and the lateral thoracic vein, and these actually serve as the sentinel nodes, as we will discuss later. And these lymph nodes then go to they carry the lymph to the higher echelon nodes, which are then located behind the pectoralis minor muscle, which are called level 2 nodes. And from there, the efferent arise, going to higher order nodes located above and medial to the pectoralis minor muscle, called level 3 or apical axillary nodes. Why do we need to evaluate axillary nodes in patients with breast carcinoma? Well, in patients with invasive breast cancer, we need to stage the presentation and get some idea about the prognosis of the patient. Therefore, we need to know how many nodes are involved in patients with breast carcinoma. And the adjuvant therapy is decided by the oncologist to a large extent based on the presence of the lymph node metastasis in the axilla. In patients where lymph nodes are already involved, the best treatment is offered in the form of axillary lymph node dissection, ALND. So it is both diagnostic as well as therapeutic role in patients with invasive breast carcinoma. In patients who present with large in situ breast carcinoma or DCIS, and if we have decided to treat this lady by operation of mastectomy, we need to evaluate the first order nodes called the sentinel lymph node biopsy, because if there is a focus of invasion or microinvasion within this area of DCIS, then again we need nodal evaluation for deciding further adjuvant therapy. Axillary nodal spread was evaluated extensively by a large number of NSABP trials in America. The notable among these is the NSAB B04, the first breast cancer trial started by great oncologist Dr. Bernard Fisher in America. It was found that in women where there was no clinically palpable lymph node, clinically N0 disease, 30 to 40% patients actually harbored microscopic foci of cancer in their nodes. So as high as 30 to 40% patients actually harbor microscopic foci of cancer cells within the axillary nodes in women who have no palpable lymph nodes. And this was the data of NSAB B04, where 362 women were randomized either to receive radical mastectomy, which was the standard of care in those days. 40% had microscopic cancer in the axillary nodes, and assuming a similar proportion will have this in the other group was treated by total mastectomy, removal of the entire breast with no further therapy, or the third group, which had total mastectomy followed by radiotherapy, and there only 2.9% patients developed axillary recurrence, as opposed to women who had total mastectomy, where 19% developed axillary recurrence. So please note that from 40% of the microscopic cells demonstrated in radical mastectomy arm, only half developed axillary recurrence clinically. If we left all the axillary nodes in situ in the body, so perhaps the body's immune system, the T lymphocytes and the cytotoxic T cells were effective, and natural killer cells were effective in killing these microscopic tumor cells. And if we offered radiotherapy in the post-op period, only 2.9% developed metastasis in the axilla. Other cells were effectively controlled by radiotherapy. So what we conclude from this B04 trial, that of those 40% which are present in microscopic form within the axilla, in clinically negative axilla, about 20%, that is only of these 20%, only half present clinically, and of those only 3% remain active after radiotherapy, i.e. 5/6, that is majority of the clinically active nodes can be controlled by appropriate radiotherapy. Does it help to remove impalpable nodes in women presenting with negative axilla? A meta-analysis was carried out way back in 1999 by a surgeon Orr, and he demonstrated that there was a minimal, about 5.4% survival benefit in women who underwent prophylactic axillary dissection compared to none. However, this was an initial study before adjuvant systemic therapy was offered to most women, and in the long term it has been found that there is no benefit even among these patients with the prophylactic axillary lymph node dissection. So the message is that if patient has no palpable lymph nodes, prophylactic axillary node dissection is not beneficial. Dr. Mona Singhani and her group carried out a meta-analysis and found the impact of axillary lymph node dissection on breast cancer outcomes in women presenting with clinically negative axilla. And this was a meta-analysis published in Cancer Journal way back in 2009. And it was observed that no survival benefit accrues by performing prophylactic axillary node dissection versus just observing these women. This is, mind you, women who have screen detected breast cancer. So message is that survival is not improved by performing prophylactic lymph node dissection if patient presents with clinically negative axilla. So surgeons tried to evaluate the axilla by some minimal access approach, and this was the study by Sir A.P.M. Forrest way back in Cardiff in 1967 in Wales in United Kingdom. He performed a study called pectoral node biopsy or axillary sampling, published in 1982. And in this study, they performed the mastectomy and a small incision in the dissection in the axilla, removing 4 nodes from the axilla, lower part of the axilla, called the pectoral node biopsy. So this is perhaps the beginning of minimal access approach to evaluating the axilla in women who had clinically negative axilla. And 4 nodes were removed starting from the lower part of the axilla. The advantage is that skip metastasis in axilla is very low, in the tune of 5% or so. Now we come to the concept of sentinel lymph node biopsy. If you see to visit the Queen, Her Majesty the Queen of England, and go to London and go in front of the Buckingham Palace where the Queen lives, you don't just barge in. You ask the guard, is Her Majesty inside? If she is, then you go inside and bow down to her and pay your respect and tribute. However, if the guard says no, Her Majesty is not inside, then you don't fiddle around there. Similarly, if you want to meet your professor, your chairman in the department, and you go to the office of your department, the surgery office, you ask the guard standing in front of the office, have you seen my chairman, my professor inside? If the guard says no, then you don't waste your time there, you don't fiddle around. And the guard is right. The guard is right because there is no backdoor entry. So we apply the same concept to the axilla. So on the gateway of the axilla, somewhere here, on the gateway of the axilla is standing a guard, a lymph node like a guard is standing on the gateway of the axilla. And the guard knows if the cancer has gone through it. So we ask the guard, have you seen cancer going inside? If the guard says yes, then we go inside the axilla and clear all the nodes. If the guard says no, and guard is right because there is no backdoor entry. Backdoor entry means that there is no skip metastasis, exceedingly rare. Then we don't fiddle around with these nodes that Mother Nature has produced for some purpose. The purpose is that to drain the lymph from not only the torso, the breast and the pectoral region of the torso, but also the lymph from the upper limb. We there is a common pathway shared by these nodes. Though the lymphatics from the upper arm and lymphatics of the breast both share a common pathway in the form of these nodes. And if we remove these nodes unnecessarily, there will be a concomitant lymphedema. And in order to avoid this, we have now embarked on the concept of sentinel lymph node biopsy. Sentinel means the guard. So again, let us explain this process. From the primary tumor, lymphatics carry the tumor cells to the first station nodes. Majority of these are located between the pectoral muscle and the lateral thoracic vein. Some lymphatics will go to other set of nodes as well, and from there the second order nodes will carry the lymph, and if tumor cells are present in it, the tumor cells as well, to the second station nodes. They are located behind the pectoralis minor. They are called level 2 nodes. So these are level 1 nodes lateral to the pectoralis minor, level 2 nodes behind the pectoralis minor, and level 3 or the apical nodes located high up in the axilla above and medial to pectoralis minor muscle. This muscle is the pectoralis minor muscle. The lymph from the efferent of the apical nodes is then taken by the axillary or subclavian lymph trunk to the junction of the internal jugular vein on the left side and the subclavian vein at the jugulo-subclavian angle near the junction of thoracic duct, and this is also joined by a lymph trunk from the jugular chain, the jugular lymph trunk, and this is the thoracic duct which is carrying the lymph from the practically whole of the body, first below the diaphragm to the thoracic duct, and it is joined by the bronchomediastinal trunk on the left side. On the right side, the jugular lymph trunk will join the subclavian lymph trunk at again the jugulo-subclavian angle, and this is how the tumor cells will enter into the venous circulation from the lymphatics. So the sentinel means a guard and one who keeps a vigil or a watch, like a sentry. So this is the first station node located in the axillary nodal basin, and it may be a cluster of nodes. It may be more than one node, and it is defined as a node which is either hot on isotope uptake, or blue if we have injected blue dye, or fluorescent if we have injected a fluorescent dye such as indocyanine green or fluorescein, or any node which is palpable in the axilla will also be called a sentinel node. So sentinel node is defined as a hot, blue, fluorescent or a palpable node. Or sometimes you will not see any blue color node, but you will see a blue color lymphatic entering into a node. That node should also be defined as a sentinel node. So it may be a cluster of nodes, and all such nodes which carry these features should be removed as part of sentinel node biopsy. Dr. Krishna Clau, a famous breast surgeon in Paris, described anatomical classification of the location of the sentinel nodes in the axilla. This was published in a famous article in British Journal of Surgery, and he found that in women who presented with T1 or T2 tumors with clinically negative axilla, 86% of these were located in this quadrangular area. Pectoralis minor here, this is the lateral thoracic vein, and this is the intercostrobrachial nerve. So if you divide this area of the lower axilla into 4 quadrants based on axillary vein here, lateral thoracic vein here, and intercostrobrachial nerve here. So you get the area A, which harbors the majority of the nodes, area B above the intercostrobrachial nerve, again medial to the lateral thoracic vein, 11% nodes. C and D constitute only 1.8%. So a very small fraction of the sentinel nodes will be located lateral to the lateral thoracic vein. So during dissection, if we are not able to find any hot or blue node, look into this area, the area between the pectoralis muscle and the lateral thoracic vein. Majority of those nodes, sentinel nodes, will be located in this area. So how do we perform sentinel node biopsy? We can use a number of dyes such as methylene blue dye or isosulfane blue dye. We can use isotopes attached to a large particulate matter such as sulfur colloid, albumin or antimony, and usual radioisotope tracer used is technetium-99, which emits gamma rays which can be picked up by a gamma detector or a gigamolar counter probe. Fluorescent dyes used in breast cancer are fluorescein, sodium and indocyanine green. A combination of two tracers, one blue dye and one isotope or fluorescent dye, has been found to have an yield of 95 to 100%. So nearly all the sentinel nodes can be picked up or identified if we use a combination of two tracers, one color dye and one isotope or a fluorescent dye. So this is an example of the operative field where we have injected the blue dye, and you can see the blue color sentinel node here. From this node is emerging the efferent, which is entering into the second station or second echelon node. So the sentinel node biopsy, and then we will send both these nodes to our pathologist for evaluation and presence of any metastasis. Sentinel node biopsy reliably predicts the axillary nodal involvement in invasive breast cancer because it permits our pathologist to have a focused approach evaluating only one or two nodes. At the All India Institute of Medical Sciences in New Delhi, we evaluated our first 500 cases in 2005. Mind you, we started our sentinel node program in 1999 after one of our surgeons, Dr. V. Sinu, learned the technique from the master in Santa Monica in California by Dr. Armando Giuliano. So learning from Dr. Armando Giuliano, the world master of sentinel node biopsy, we started our initial validation program. The validation means that you perform the sentinel node biopsy and then follow the removal of rest of the axillary nodes and then send as two separate samples, the sentinel node as one sample or in one specimen bottle, and the rest of the axillary nodes will be sent separately and as a separate specimen, and then you evaluate how many times you found the cancer cells in the sentinel nodes and in the rest of the axilla. And this is how you calculate the diagnostic indices for sentinel node mapping in the form of identification, the sensitivity and the false negative rate. So we achieved a reasonable identification of 91% with a combination of blue dye and isotope, technetium sulfur colloid, with an overall accuracy of 97%, sensitivity of 91%, a false negative of 8%, so which was similar to the global standard. Since then, we are offering this technique for the treatment of women presenting with early breast cancer as a therapeutic modality. So see, these are some of our publications. I'll leave it for you to go through and peruse at your leisure time. One of the professors, Dr. Sinu, also carried out a randomized trial to evaluate two different types of blue dyes, namely methylene blue, which is very affordable and has less side effects compared to lymph, the expensive blue dye that is patent blue. And this was a randomized trial, two-arm randomized trial. Half the women randomized to receive methylene blue along with isotope, and other half were offered the sentinel node mapping with patent blue. And isotope was the same, technetium sulfur colloid, in both the arms. So we found that 97% of women, we were able to identify sentinel node biopsy in the methylene group arm and 86.6% in the patent blue arm. So almost similar with no statistical difference between the two groups. Sentinel node positive patients were 32% in the methylene group arm and 20.87 in the patent blue arm. Again, hardly any difference between the two groups. Total number of sentinel nodes identified with the methylene blue was with a mean of 2.73 and a standard deviation of 1.7. Again, very similar, 2.55 is the mean with patent blue with a standard deviation of 1.7. So we could identify the blue sentinel nodes with the help of methylene blue, which was exactly similar to that achieved by patent blue violet. So since then we are using methylene blue in our study, and we are popularizing the use of methylene blue in the low and middle income Asian countries, because it is easily available and quite affordable compared to more expensive patent blue. So axillary sampling is another alternative to evaluate axillary node involvement in patients presenting with clinically negative axilla, where we dissect a block of tissue located between the pectoralis major muscle and latissimus dorsi, located below the intercostobrachial node. So lower part of the level 1 tissue is dissected, lying below the intercostobrachial nerve, and this block of tissue is then sent for evaluation of any involvement. Based on that, we can perform the axillary node dissection if the nodes are involved. We should learn how a pathologist in his laboratory evaluates these sentinel nodes. So this will be based on the size of the node involved. If the node measures less than 5 millimeter in size, very tiny small node, then they will just bisect it and make it into 2 halves, and then both halves will be evaluated by histological evaluation. If the node measures more than 4 millimeter in its longest dimension, then we'll make slices of 2 millimeter each. So this is a 2 millimeter slice, and such slices will be made. The idea of making 2 millimeter slices, the fact that a macrometastasis in the sentinel node is defined as a tumor focus measuring more than 2 millimeter in diameter. This is macrometastasis. So it is more than 2 millimeter. So if you cut 2 millimeter slices of a node, you will capture this macrometastasis, if not here, at least here. So that's the logic behind slicing the node, which is larger than 4 millimeter in dimension, at 2 millimeters diameter slices. If tumor focus in the node is less than 2 millimeter, measuring between 0.2 millimeter to 2 millimeter, we call it micrometastasis. Micrometastasis 0.2 to 2 millimeter in diameter. So more than 2 millimeter would be called macrometastasis, less than 2 up to 0.2 will be called micrometastasis. And what do we call if we have any tumor cell or a group of cells measuring less than 0.2 millimeter? So they will be called isolated tumor cells. They are scattered here and there within the lymph node, and sometimes they may not be visible to the usual pathologist eye on hematoxylin and eosine stain, such as in this staining of hematoxylin and eosine. Then we use a special stain called pancytokeratin or CK19 staining. The breast cancer cells are derived from epithelial cells from the ducts or the lobules. Epithelial cells have cytokeratin as their cytoskeleton. So presence of a cell containing cytokeratin positive molecule indicates the presence of epithelial cells within the lymph node. Lymph node is a mesodermal structure, and no cytokeratin is present within the lymph node. So presence of cytokeratin positive cells is indicative of metastasis of the epithelial cell origin. And the isolated tumor cells can also be discerned or delineated using these special cytokeratin stain, which are missed by conventional staining of hematoxylin and eosine. One of the earliest large randomized trial evaluating the role of sentinel node mapping in women presenting with early breast cancer and clinically negative axilla was published by Dr. Robert Mansell, professor of surgery at Cardiff Breast Unit, and he published it as the name Almanac trial trial with the Professor Robert Mansell as the PI was published way back in 2006 in Journal of National Cancer Institute, JNCI, where 1,000 women from across various breast centers in Britain were randomized either to receive sentinel node mapping or full axillary treatment in the form of either 4-node sampling or full axillary dissection. And it was observed at the end of 1 year, the occurrence of lymphedema was only 5% in patients who had sentinel node mapping compared to 13% women following full axillary dissection. The incidence of sensory loss was only in the tune of 11% in women undergoing sentinel node mapping compared to 31% of sensory loss in women having full axillary dissection. Thus, the relative risk of lymphedema was reduced to 1/3 or 0.3 by performing sentinel node mapping. Similarly, the risk of sensory loss was also reduced to 0.3 or 1/3 by performing sentinel node mapping compared to full axillary dissection. Since then, a large number of trials have been published in the literature, and this is a summary of a systematic review published in Journal of American Medical Association, JAMA, in 2013, where long-term adverse outcomes associated with different axillary operations are published. The lymphedema occurred in the tune of 10 to 20% patients in different series in women who had undergone full axillary node dissection compared only to 5 to 7% women where only sentinel node mapping was carried out. So 10 to 20% with full ALND and 5 to 7% with sentinel node mapping. The quality of life reduction due to various symptoms, frozen shoulder, difficulty in movement of the arm, pain in the shoulder area, pain in the upper arm, was noticed about 1/3 of the patients, 35% had reduction in the scores of the quality of life compared to only 23% women had a reduction in the quality of life scores if they had their axilla assessed by sentinel node mapping. The arm pain and the numbness was also nearly 1/3, only 11% women after sentinel node mapping compared to 31% in those who had full axillary node dissection. So we can notice that all the major adverse effects of full axillary node dissection can be minimized by carrying out this minimally invasive approach, that is sentinel node mapping in women with early breast cancer and clinically negative axilla. What is the impact of sentinel node mapping on axillary recurrence is listed on this table. Data from large centers from Milan Institute of Oncology in women who had negative sentinel node mapping with a follow of 38 months. Local recurrence was only 0.3% in the axilla. In the Memorial Sloan Kettering data from New York, women who had negative sentinel node biopsy, again with a 31-month follow-up, we had 0.12% of the local recurrence in the axilla. Similar, another study by Moffitt, women who had negative sentinel node up to 60-month follow-up, only 0.26%. So extremely low recurrence is observed in the axilla if sentinel node biopsy is negative. What happens if we have positive nodes? Well, there is one such a study, and mind you, here patients decided. Patient's choice was that in spite of a positive sentinel node, they will not have further axillary surgery, and we have to honor patients' desires in deciding the treatment for patients with breast cancer. And it was observed that if they had micrometastasis, again the axillary recurrence occurred in the tune of 0.3%, very similar to the negative sentinel node mappings, indicating that presence of micrometastasis in the axilla in the sentinel node probably has the same impact as the negative sentinel node mapping. If they had macrometastasis, then axillary recurrence was slightly higher, again less than 1%, 0.7%. So even with positive sentinel node, small numbers, small tumor burden in the axilla, we have extremely low recurrence within the axilla. So what are the options available to a surgeon if sentinel node biopsy is reported as positive? Well, we have the three options. Either perform just observation and provide all the adjuvant therapy decided by the oncologist in the form of radiation therapy, adjuvant chemotherapy, hormone therapy, or other targeted therapy. Or we perform a full completion axillary lymph node dissection. And the third option is that offer radiotherapy to the axilla. And two trials have tested this hypothesis. One has already completed, the Amaros trial in Europe and England, and the POSNOC trial, which is an ongoing study in Britain. A large multicenter study evaluated the role of sentinel node biopsy versus axillary node dissection in women where sentinel node biopsy reported presence of only micrometastasis, and it was observed that in women where the sentinel node is harboring only micrometastasis, there is no deterioration in the disease-free survival. The disease-free survival was 84% versus 88%, whether you perform the axillary node dissection or not. So the conclusion is that sentinel node biopsy with micrometastasis alone, it is safe if we leave the axilla untouched and offer other forms of adjuvant therapy. If we have macrometastasis, then what to do has been addressed by this large trial known as American College of Surgeons Oncology Group, or ACOS OG Z0011 trial, with the principal investigator being Dr. Armando Giuliano, and this is the famous Z0011 trial. Women with T1 or T2 tumor clinically negative axilla were offered breast conservation, and if sentinel node were positive, up to 2 positive macrometastasis sentinel nodes, then they were randomized either to have full ALND axillary dissection, only observation of the axilla with systemic adjuvant therapy. So the trial started way back in 1999 and finished recruitment in 2004. 165 investigators from 177 institutions took part in the study, and the target was to accrue 1900 patients, but the trial ended prematurely with only 891 patients, and this is the breakup of the outcome reported by Dr. Giuliano. Axillary recurrence occurred in 0.9% women who had sentinel node biopsy alone, as opposed to 0.5% following full axillary node dissection. The adverse events were much less in the form of lymphedema, shoulder dysfunction, etc. Only 25% in sentinel node group and 70% in axillary node dissection. Overall survival 92% in the sentinel node arm, 91.8%, exactly similar survival in both the groups. And this slide shows the inclusion criteria for women aged 80 and above, T1 and T2 tumor, clinically negative, no evidence of metastasis. Sentinel node had to have macrometastasis, either reported in frozen or touch preparation or H&E staining, and treatment has to be in the form of a lumpectomy with negative margins. Patients having mastectomy or no radiation therapy were excluded, and patients with large tumors were also excluded. So this is the consort flow diagram for women who had undergone the Giuliano Z0011 trial. 445 patients recruited in the ALND arm and 446 in the sentinel node biopsy arm, and then with the intention to treat sample, we evaluated 388 patients in the ALND arm, 425 patients in the sentinel node biopsy arm. So this is the age distribution and clinical parameters. They were all balanced within the two groups. Type of carcinoma, histologically infiltrating duct carcinoma in the majority of women. In both the groups, almost similar distribution. Chemotherapy was offered nearly to the same proportion of women, and so is true for patient receiving endocrine therapy. The local regional recurrence was reported as a long-term outcome of this trial, way back in 2016 in Annals of Surgery, and here is the result. At 9 years of follow-up, women undergoing ALND had local recurrence of 5.8%, and in the Sentinel node group, local recurrence of 3.8%. Regional recurrences 0.5 here and 1.5 here. So almost similar recurrence. At the cumulative 10-year local recurrence is reported here. The blue bar represents the data from women undergoing ALND, and the maroon bar represents the data for women undergoing sentinel node biopsy. So the cumulative local recurrence occurred in 5.8% following ALND and 3.8% following sentinel node biopsy. No statistically difference on the p-value. Cumulative regional recurrence or CRR occurred 0.5% in the ALND group and 1.5% in sentinel node, slightly higher p-value, slightly more than 0.5, so not attaining statistical significance. Cumulative loco-regional recurrence, that is taken local plus the regional together, 6.3% in the ALND arm versus 5.8% in sentinel node biopsy, again no statistical difference. If we take the overall survival with the purple line representing the data from women undergoing axillary node dissection and the green line representing those who had axillary radiotherapy, again there's no difference. The two curves almost overlap till the very end, and then there is a bit of divarication at the end of the follow-up. Disease-free survival, again the two lines, the purple line representing the axillary node dissection data and the green line representing the information from those having axillary radiotherapy. The two lines almost overlap each other. So what to do after mapping axilla? Offer radiotherapy or surgery to the axilla has been addressed in this trial called AMAROS. AMAROS is an acronym for this, after mapping axilla, radiotherapy or surgery. And this was a EORTC breast cancer group trial, and with Dr. Rutzer from Netherlands as the PI and Professor Robert Mansell as the PI from the United Kingdom. Eligibility criteria: T1, T2 tumors up to 5 cm in size, clinically negative, undergoing either breast conservation or mastectomy, any age, and with prior informed consent were included. Patient with multicentric disease, neoadjuvant chemotherapy was an exclusion criteria, and presence of prior malignancies. So 4823 patients were registered. Of these, 4806 were randomly assigned either to have axillary lymph node dissection or to only axillary radiotherapy. And this is the final sample which was analyzed by intention to treat analysis. 744 after sentinel node and 681 were axillary node positive, sentinel node mapping. The axillary recurrence in the women undergoing ALND was exactly similar to those where axillary nodes were treated by axillary radiotherapy. The blue line and the red line overlap from the beginning down to the end of the follow-up. Axillary recurrence rate was noted in 4 out of 744 women undergoing ALND, 0.43% versus those having axillary radiotherapy, 1.19%. No statistical difference, significant difference was observed, with the survival curve line overlapping exactly till the very end of the follow-up. Women having micrometastasis, axillary recurrence occurs in exceedingly low proportion of women, 0.2% if you have micrometastasis, and if you do not offer any further therapy, only 1.9%. Presence of macrometastasis as shown in Z11 trial, 0.5% after axillary clearance, 0.9% after observation of the axilla alone. In the AMAROS trial, we observed that radiotherapy in the axilla has a recurrence rate of only 1.2% as opposed to 0.4% with axillary clearance. A post-NOC trial is ongoing with Dr. Amit Goel as the PI in UK, here T1 and T2 tumors with clinically and negative and no metastasis. N0 and M0 patients are being evaluated. Ultrasound in the axilla is performed to exclude those who have suspicious nodes, and if the nodes are negative, then they are being randomized to sentinel node biopsy, and breast cancer is being treated either by wide local excision or mastectomy. So both lumpectomy and mastectomy patients are being included in this trial. The trial is ongoing and we are waiting for the final results to be published. So the ASCO guidelines published in 2016 suggest that if the sentinel node is negative, do not carry out any axillary node dissection. If you have 1 to 2 positive macrometastasis sentinel node and patient is having breast conservation surgery, again no axillary dissection is recommended. If you have positive sentinel nodes and patient is having mastectomy, axillary node should be performed. Patients with large tumors, T3 and T4 tumors, or those presenting with inflammatory breast carcinoma, recommendation is perform full axillary node dissection. There is no role of breast conservation and no role of sentinel node mapping in these patients with advanced cancers. What to do if patient has advanced cancer and we offer primary systemic chemotherapy or neoadjuvant chemotherapy has been addressed in this trial. False negative rate has been found to be very high if we remove less than 3 nodes in the tube, up to 20% with a single agent, and if you use dual tracers it can be brought to 10%. So if more than 3 nodes are removed, false negative rate can be reduced to less than 10%. So now we have observed an era of de-escalation of axillary surgery in the form of use of biomarkers to assess the systemic therapy and not the axillary node involvement. Sentinel node concept is now being used more and more in evaluating the axillary nodal involvement and deciding further adjuvant systemic therapy in women with low burden of axillary disease. 2 European trials are on way. One is Sound trial in Italy, where patients are being evaluated where no axillary surgery is carried out, and similar trial in Germany called INSEMA trial is evaluating 5940, a large number of patients being evaluated where sentinel node versus no axillary surgery is being carried out. Let us appreciate various pitfalls and shortcomings associated with axillary nodal assessment in patients with breast cancer. Most important fact to appreciate is the issue of sentinel node biopsy in patients suffering from locally advanced breast cancer. Current data does not support the use of sentinel node mapping in patients who present with initial advanced stage of disease in the breast in the form of large tumors more than 5 centimeter in size, that is T3 tumors, and T4 tumors, that is tumors involving the skin of the breast and underlying chest wall, and also the patients with inflammatory breast cancer. In all these situations, some authors have attempted to carry out sentinel node mapping, but have reported very high and unacceptable levels of false negativity with sentinel node mapping. Hence, it has not been accepted as a standard of care for patients either with locally advanced breast cancer or with inflammatory breast cancer. We should also appreciate that we do not have very solid evidence in support of performing sentinel node mapping after initial neoadjuvant chemotherapy for women presenting with locally advanced breast cancer. Moreover, there is the need for training surgeons, pathologists, operative room associated personnel like scrub nurse and nuclear medicine physicians in obtaining optimal results of sentinel node mapping. And of course, there is a need of providing radioisotope injection to the patient and the need of radioactivity detection gamma probe, which is very expensive. So, what is the way ahead? What can we do to circumvent these problems and issues? Obviously, there is need of more research in this area. We have to train our surgeons and other associated personnel in the performance of sentinel node mapping and in ultrasound evaluation of the axillary nodes. One alternative to the use of radioactive tracer in performance of sentinel node mapping may be a fluorescent dye such as Fluorescein or indocyanine green in combination with blue dye methylene blue. In order to develop this fluorescence based sentinel node mapping technique, research was carried out at the Advanced Center for Training Research and Education in Cancer Research Wing of Tata Memorial Center in Mumbai. In short, it is called ACTREC, which ACTREC serves as a bridge between the basic sciences and clinical oncology. A research project was undertaken in the name of fluorescent dye guided sentinel node mapping and Raman spectroscopic assessment of sentinel node biopsy in patients with breast cancer. Fluorescein sodium solution was used to identify the sentinel nodes. At this time, there was only one study reporting the role of fluorescein sodium in sentinel node mapping for patients with colorectal cancers. Group of workers in Michigan State University led by Dan et al. Had performed initial study on 120 patients with colorectal cancer, and they had shown that fluorescein sodium could actually replace the gold standard being used at that time, that is lymphazurin and isosulfane blue. So, we carried out a study at ACTREC where a combination of fluorescein sodium, methylene blue and radio tracer technetiums tagged to albumin was used. Blue dye helps in identification of the dermal lymphatic plexus very nicely. The fluorescent lymphatics can be nicely visualized using blue light of 480 nanometer wavelength. A lateral memory crease incision helps in identifying the lymphatics traveling from the nipple areola complex and the dermal lymphatics of the breast if an incision is placed along this lateral memory crease. Dissection deep to the axillary fascia then reveals these shiny fluorescent lymph nodes and lymphatics, which are then dissected and the blue and fluorescent nodes are removed. In this patient, we were able to identify 4 nodes in such manner. The initial results of this study using a combination of fluorescein, methylene blue and radiotracer was quite encouraging, and based on that we evaluated its results at the Tata Memorial Hospital in Mumbai. We obtained acceptable identification of lymph nodes with fluorescein in 92% of patients as opposed to identification with technetium sulfacolloid in 96% of patients. We achieved a false negative rate of 8.3% when we used a combination of the tracers. This result was presented in the San Antonio Breast Cancer Symposium. Based on these encouraging results, we then embarked upon a randomized trial with non-inferiority hypothesis at the All India Institute of Medical Sciences, New Delhi. This is an ongoing trial, and so far we have achieved an identification of sentinel nodes when we used a combination of fluorescein and methylene blue in 84% of patients, which is similar to that achieved by combination of radiotracer with methylene blue. These results have been presented in the San Antonio Breast Cancer Symposium. This technique has also been validated by a group of breast surgeons led by Professor Gaurav Agrawal, who is an eminent breast surgeon at the Sanjay Gandhi Memorial Postgraduate Institute in Lucknow. They have achieved an identification with fluorescein and methylene blue in 95% of patients, achieving a sensitivity of 93% and a false negative of 6.3%. Based on these results, we could suggest that a combination of fluorescein and methylene blue could perhaps be adopted world over, because it is offering an affordable, low cost, effective and safe alternative to the conventional combination of radioactive tracer along with the blue dye. In conclusion, we will submit that patients with invasive breast cancer presenting with a clinically negative axilla, an ultrasound evaluation of the axilla should be carried out. Any suspicious node should be biopsied. If found positive, should proceed to performing axillary lymph node dissection or ALND. However, if patient has both clinically and sonographically negative axilla, or if the biopsy of the suspected node is negative, we should proceed with sentinel node biopsy. In patients where histological examination of sentinel nodes reveals presence of macrometastasis in up to 2 sentinel lymph nodes, axillary radiotherapy can be offered as a viable option to full axillary dissection. Where we find 3 or more sentinel nodes positivity revealing macrometastasis, perhaps axillary lymph node dissection is the best therapeutic option based on current evidence. For women presenting with locally advanced breast cancer or those who are coming after neoadjuvant chemotherapy and with inflammatory breast cancer, axillary sampling or full axillary dissection remains the most effective and safe option for dealing with axillary lymph node metastasis. The future lies in training the surgeons and pathologists in performing and evaluating sentinel lymph nodes and generating level 1 robust evidence in favor of axillary sentinel node biopsy based on fluorescent dye fluorescein sodium. Thank you very much